Hello, my name is Sarish, and I'm a PGY3 internal medicine resident at Franciscan Health Olympia Fields Hospital. I will be presenting a case titled Beyond Basic, a case study of severe metabolic alkalosis. First, as an introduction, metabolic alkalosis is defined as a disease state where the body's pH is elevated to a value greater than 7.45, secondary to some metabolic process. Before going into details about pathology and this disease process, some background information about the physiological pH buffering process in the human body is important. The primary pH buffer system is the bicarbonate carbon dioxide chemical equilibrium system, which can be broken down into hydrogen ion plus bicarbonate to carbonic acid to carbon dioxide plus H2O. Bicarbonate functions as an alkalotic substance. Therefore, increases in bicarb or decreases in CO2 will make the blood more alkalotic. The opposite is also true, where decreases in bicarbonate or an increase in CO2 will make the blood more acidotic. pH levels are physiologically regulated by the pulmonary system through respiration, whereas the bicarbonate levels are regulated through the renal system with reabsorption rate. Therefore, metabolic alkalosis is an increase in the difference between strong cations and anions, also known as the strong ion difference. There is a multitude of disease states that induce metabolic alkalosis. In general, the causes can be narrowed down to an intracellular shift of hydrogen ions, gastrointestinal loss of hydrogen ions, excessive renal hydrogen ion loss, retention or addition of bicarbonate ions, or volume contraction around a constant amount of extracellular bicarbonate known as contraction alkalosis, which can be seen with active diuresis. All of which leads to a net result of increased levels of bicarbonate in the blood. As long as renal function is maintained, excessive bicarbonate is excreted in the urine fairly rapidly. As a result, metabolic alkalosis will preserve if the ability to eliminate bicarbonate is impaired due to one of the following causes: hypovolemia, reduced effective arterial blood volume; chloride depletion; hypokalemia, reduced GFR, and or hyperaldosteronism. An uncommon cause that we often do not think of for metabolic alkalosis is bowel obstruction. Bowel obstruction, especially in the small intestine, results in metabolic alkalosis from dehydration and loss of gastric hydrochloric acid, specifically if the patient is concurrently vomiting. Such is the case that I will be presenting today. This is a 50-year-old male with a past medical history of stage 4 colonic adenocarcinoma and recent hospital stay for bowel obstruction who presented with a 3-day history of emesis, which started after his last chemotherapy session. He was tachycardic, hypokalemic, hypochloremic, had extremely high bicarbonate, and an acute kidney injury. Abdominal X-ray was negative for obstruction. On day 2, the patient's condition worsened. He continued to have emesis to the point where he became altered, and his GCS was found to be about 8 or 9, and at that point, decision was made to move him to the ICU. Labs are obtained with an ABG, significant for an alkalosis, of 7.74, with a PCO2 of 75.4. CT imaging was obtained and was notable for small bowel obstruction. Multiple efforts were made by multiple services, including nephrology, general surgery, and ICU. Efforts included intubation, NG tube placement, proton pump inhibitors, acetazolamide, and dialysis. All efforts were futile and ultimately led to the patient's death. On my poster, I have included a graphic that shows the severity of alkalosis with pH of 7.7 in this patient, along with the bicarbonate concentration when the pH was that high. I have also included a graphic showing how the kidney is able to utilize various mechanisms in order to gain or lose bicarbonate, but if a patient is in renal failure, these mechanisms cannot be used. All in all, metabolic alkalosis is a common phenomenon seen in the hospital setting, for example, with vomiting or diuretic use. We should not underestimate the mortality associated with severe metabolic alkalosis. Mortality is as high as 45% when a patient has a pH of 7.55 and 80% when the pH is above 7.65. Multiple medications have been known to help with metabolic alkalosis, some of which we've used. Unfortunately, even with prompt treatment, patients with severe metabolic alkalosis rarely survive. All in all, I would like to thank Dr. Coolidge, Dr. Sarger, and Dr. Schaefer for their assistance with this case. And thank you, ACP, and my residency program for the opportunity to present this interesting case. Finally, thank you to you for listening to my presentation.